Hello, my name is Jay Huang. I'm a fourth year pathology resident in the United States. I will go over cases almost on the daily, and if you're interested in that, just cases from head to toe, consider giving a like and subscribe. Without further ado, thank you to UPMC for this case. This is case 1103. Let's learn about extramammary Paget disease of the penis, a rare case report. Thank you to Dr. Patwardhan and Dr. Quiroga Garza. So this is a man in his 60s presented to the hospital with history of urothelial carcinoma. The patient is status post-radical cystoprostatectomy with neobladder creation 8 years prior to the current presentation. Subsequently, the patient had multiple recurrences of the carcinoma involving the ureter, which was surgically managed. During the present presentation, the patient had intermittent hematuria and was also found to have a penile lesion. Both urethral and penile lesion biopsies were performed and diagnosed as urothelial carcinoma and extramammary Paget disease, respectively. A partial penectomy was the recommended treatment option and was subsequently performed. The penectomy specimen was evaluated for the presence of the disease and any other pathologic findings. So histopath, we have a partial penectomy specimen consisting of glans penis with attached urethrectomy was received. A white TLO, rubbery, ill-defined and infiltrating vaguely nodular mass, 7.4 by 1.2 by 0.5 centimeters, was identified surrounding the urethra in the proximal, mid, and the distal one-third. The glans penis, the urethra, and the corpus spongiosum was grossly involved by the mass, while the minimal corpus cavernosa seen for evaluation was not involved. Microscopic evaluation confirmed the presence of recurrent invasive papillary urothelial carcinoma, high grade, arising from a background of multifocal urothelial carcinoma in situ, so there's a field effect. The carcinoma extended throughout the length of the penile urethra and invaded into the adjacent corpus spongiosum, adipose tissue, and glands. No definitive lymphovascular invasion or perineural invasion was seen. Also noted was extensive Paget disease on the gland surface, so it's in figure 1. Let's see. So we have spongiosis, we have a granular layer, but in the epidermis we see very vacuolated cells infiltrating upwards into the stratum spinosum. And these cells are pleomorphic, as you can see here. On IHC, the Paget cells were positive for CAM5.2, CK7, P63, GATA3, uroplakin2-3, while negative for CK20, monoclonal CEA, GCDFP15, S100, and melon A. So these cells are most likely positive. These are urothelial carcinoma cells that has pagetoid spread into the epithelium because this GATA3 is positive, uroplakin2-3 is positive, meaning this is from the urothelium. So CK7, we have crisp membranous staining. CK20, staining. Remember, CK7-20 positivity is seen in bladder. It can be seen in stomach and pancreaticobiliary as well. GATA3 is positive nuclear, which can be seen in breast, but also bladder, and it can be seen in pancreaticobiliary, some of the pancreaticobiliary cancers. P63 is positive, and CAM5.2 is positive as well. So let's go to the discussion section. So extramammary Paget disease is an extremely rare entity which has been more commonly described in older adults. A SEER analysis performed in 2011 found 328 cases of penis and anorectal extramammary Paget disease from 1973 to 2007. Median age for the diagnosis of scrotal and penile disease was 70.4 years and 73.6 years respectively. The disease has been associated with GU or GI cancers, either synchronously or metachronically. Although the exact incidence of secondary malignancy in this case is unknown, the incidence of a separate primary malignancy was 45% in a study by Hagar T. et al. In our case, the patient had an associated urothelial carcinoma. IHC stains can be helpful in the differentiation of primary extramammary Paget disease and secondary extramammary Paget disease. GCDFP15 can be positive in some primary cases, while it tends to be negative in secondary, especially secondary to colorectal or urothelial carcinoma. In our case, GCDFP15 was negative. CK7 and CK20 is another group of stains which is useful in differentiating primary and secondary EMPD. Most commonly, primary EMPD tends to be CK7 positive, CK20 negative. Secondary EMPD from colorectal carcinoma tends to be CK7 negative, CK20 positive, while extramammary Paget disease secondary to urothelial carcinoma tends to be both CK7 and CK20 positive because urothelial carcinoma stains with CK720. However, aberrant staining patterns in these scenarios has also been described. Our case showed positivity for CK7 but was negative for CK20. It was also positive for uroplakin 2-3, which can be another marker useful in the diagnosis of secondary EMPD. Oh, I thought this was positive for CK20, but I guess they had interpreted it as negative, so my apologies for that. The patient was treated with surgery, chemotherapy for underlying urothelial carcinoma, and had not demonstrated any disease recurrence until last follow-up. Because of the rarity of this disease, different treatment modalities have been tried. However, wide local excision is used more commonly in the management of extramammary Paget disease. All right, well, the key point is extramammary Paget disease, you want to differentiate between primary and secondary. Primary, oftentimes GCDFP15 will be positive. Secondary, and primary will be CK7 positive. Secondary will, if it's colorectal, will be CK20 positive, and urothelial CK720 positive. All right, well, I will talk to you all later. I hope you have a good one, and take care. Bye.